Hello everybody, we're back for another fertility Q&A tonight. We are going to be joined by Dr. Jessica Bauer of IVFMD, and she should be coming on in a few moments. We are going to be taking all of your questions. I know that you have a lot of them because we've been getting them submitted throughout the week, but we still have time for plenty. If you still want to type them in the comment section below, we'll be happy to answer them for you. My name is Dr. Farrar Duro. I'm a reproductive acupuncturist, and I am Florida Complete Wellness. I'm in Hialeah Gardens, and we work with patients who are anywhere on the fertility journey, whether it's trying to conceive naturally or alleviating painful periods, helping with PMS, mood swings, those things, and also trying to conceive via IVF or IUI. We help support you in that journey. So I do see Dr. Bauer here, so jump into the conversation here, and she should be coming on shortly. Let me go ahead and there she is. Hello. Oh, we did it this time. We're like, yes.
Yay.
We're so tech savvy here.
Oh God, I'm so embarrassed. It's
not.
I have other good qualities, I promise.
Don't worry. I have the same effect on things. They tend to break around me when I'm trying to use them, technologically speaking. So thank you for coming on, and we are gonna have some fun tonight answering your questions. So you can ask us whatever. No questions too silly, so don't worry. Well, maybe some, but usually not. So we'll get to that. And Dr. Bauer, if you could introduce yourself too.
Yeah, absolutely. So hi guys, I'm Dr. Jessica Bauer. It is so nice to meet all of you. That if I haven't met you yet, I am a physician at IVFMD. I actually work in a bunch of the IVFMD offices, so gives you a great opportunity to come and see me. I'm out of the Jupiter office, I'm out of the Boca office, and I also work up in sort of more North Florida in the Melbourne Vieira office. So ready to see you whenever and wherever, or you can see me virtually, and it doesn't matter where the office is.
You're the newbie, the new kid on the block here.
I am. I'm the newest addition, although I've been, I guess in about a month, it'll be a year, which is totally crazy to believe.
Oh, so. Wow. Okay. So you started kind of when all of this pandemic started, like it was kind of
right in the middle of it. They were like, sure, we're still busy, so let's bring on another doc. So
yeah. Yes. Actually, you guys were still open during, the time where we were not sure what was going on. So
it was a crazy time, and I can't even imagine how busy we would be right now if we had closed, because we're rocking and rolling at IVFMD. So.
And as far as appointment times go, are you guys still kind of? I know a lot of the doctors are booked out in advance for several months. Is someone able to get an appointment with you pretty soon, or like what's the time?
So of everyone, you can definitely get an appointment with me probably the soonest, at least a new patient appointment, and that's just we're actively working on trying to improve that, but there's just so many people and only so many doctors, and but definitely no, I think you can definitely see me within at least a couple weeks as far as I know. And then you should always make sure that you're asking about a cancellation list for your doctor.
I always tell people to do that. Yeah, on the list.
Things come up for sure, and if you can be available, I know it's tough with work and everything, but if you can be available, there's a high likelihood that we can see you sooner. So.
Very cool.
Yeah.
Awesome. So, and virtual is a good thing too. So just
absolutely, it's easy, and we're worth the wait. So.
Yes, yeah, you guys are awesome. Yeah. Okay, so I think we should kick off with some questions that we've got submitted earlier about the first one's about Ovasitol, and I know that you have a nutrition background too, so I would like to know what you think about this. So the question is, does taking Ovasitol, which is a myo-inositol powder, help with trying to conceive? I dropped birth control a year ago.
Yeah, so Ovasitol is a great product. I have no financial interest in this company. I just happen to like the product. It's made by Theralogics. And Ovasitol is actually, as you stated, a myo-inositol, but it's also a combination of myo-inositol and what we call D-chiroinositol. So it's like sort of a different chemical formulation. And the benefit of inositols in patients that actually have has been most found in patients that have PCOS. And what it has been found to show is that generally women with PCOS have a larger number of eggs than usual for someone their age, because they're either they were just born with that way, or they don't lose their eggs at a rate that is like a normal person, because they might not have regular menstrual cycles or something like that. And so a woman with PCOS has more eggs than she's able to nourish well. Excuse me. And so the inositols have been shown to help nourish those extra eggs that you have. But it's very important that the inositols are in the appropriate ratio, and it needs to be in a 40-to-1 ratio. And that's what this product is, which is why I like it. And it's like a little powder that you put in like a glass of water twice a day. And so it can certainly help patients with PCOS. So to answer this question, if this patient has not been diagnosed with PCOS, I might go ahead and ask your doctor before before using it, to make sure that it is the appropriate choice for you. But generally speaking, it definitely can help PCOS patients.
Very cool. Yeah, definitely. And we've had a lot of patients say that it also helps them regulate their cycle too. So if they have PCOS with irregular cycles, it does take time though, I've noticed.
Absolutely.
And okay, so that without knowing like more history, I think like maybe that person was on birth control to regulate the cycles, and they're trying after that. But I think again, it's good to kind of know more of the details about, like you said, the reasoning behind it for sure for that. Okay, and then how long does it normally take to get a male's semen SA sperm count up after starting Clomid?
Clomid, just so everyone understands, so Clomid, normally you think of women taking it, but it actually has the same, you can use it in men because of the effect that it has on a specific hormone called follicle stimulating hormone, because it tricks the brain, regardless of if it's in a male or a female, into thinking that there's not enough estrogen around. And the way that estrogen is created or stimulated is by releasing follicle stimulating hormone, or FSH, from the pituitary. And in men, the effect of FSH on the testicles is to generate sperm. That's a tough question. Also a tough question to answer without getting a little bit more background. It depends on where the semen and like where you're starting from, right? So if you really have little to no sperm, using Clomid for maybe 6 months might help, but it might not. If you're just trying to boost a mildly low or moderately low sperm count, I would think that you would see generally in about 2 to 3 months that you would see an improvement in the sperm count. Generally, the life cycle of sperm is about 3 months. And so the Clomid will need to affect the upcoming crop of sperm. And so sometimes it can take up to 3 months to see an effect.
Okay, good. So, and definitely, those have taken testosterone, that's not good. So, that's a factor. Get off of that, eat healthy, stay away from hot tubs.
Yes, seriously. Yeah, no. Please think twice if anyone is thinking about, if someone recommends testosterone therapy to you. There are certainly indications for it, and I'm not saying that it's a bad thing. It's just not. You need to know what it does to sperm, which basically shuts down sperm production. If you and your partner are trying to conceive, testosterone replacement therapy might not be the appropriate choice right now.
It's like male birth control, right?
100%.
Yeah, and I noticed that a lot of younger guys are on this, so now it's a big thing. So So can endometriosis affect implantations? Another question we have, and if so, laparoscopy before IVF.
Yeah, so endometriosis in general can be, these women can have elevated levels of inflammation throughout their body because of the endometriosis. And therefore, if you have a highly inflammatory state, that can certainly decrease the chance of implantation. If you are someone that really doesn't have, the question about doing surgery, which is the laparoscopy before IVF, really has more to do with the symptoms that the patient has. You wouldn't necessarily want to go ahead and do a surgery if a patient, is not having particularly painful periods and if their life is not particularly affected by their endometriosis, because certainly surgery comes with its own risks. It is not necessary. It's not like a go-to thing that I do to do surgery on an endometriosis patient before IVF. Sometimes if you're looking to try to suppress the endometriosis and keep the inflammation at bay, sometimes a short course of birth control pills or a medication called agestin can sometimes help, but it has to be in the right patient, because in the wrong patient, that can overly suppress the ovaries and make the IVF stimulation harder. So it's really it's a conversation that you certainly should have with your doctor about understanding the pros and cons of each. But I wouldn't say it's my go-to approach to endometriosis of patients.
Definitely. And
and the other thing, obviously, that goes without saying, the other thing that can really help endometriosis patients, not only with pain, but inflammation and whatnot, is acupuncture, 100%. Yeah. So I always recommend that as well.
Awesome. Yeah, definitely. It's very helpful. And I haven't noticed that there's been that many of our patients who've had laparoscopies lately, I guess. But I mean, prior to IVFs, I don't think that that's really minimized lately. I mean,
yes,
like in the past 10 years, I guess you could say, like,
yeah.
Yeah,
no, for sure. It definitely, in my opinion, and it's just my opinion, surgery has much more of a role in endometriosis patients to improve their quality of life and improve their discomfort with periods. That really is more of the role, in my opinion, as opposed to a better outcome from a fertility and IVF standpoint. But every doctor is different.
Yeah, and the way that you guys test for any kind of inflammation or endometritis or all those things that could go wrong, I guess, with implantation, that is more, I guess, suspect in patients with endometriosis, that maybe there is some natural killer cell elevation going on, all of that. So that's already tested for when you guys are doing a lot of your procedures that you do, or the ERA, or which we'll get to a question about. That's our next question, actually, about ERA. But that test, I mean, I think that Dr. Gelman had mentioned on a live that we did that there's a test where during that time, during the ERA, you can actually do a biopsy, an endometrial biopsy, and you can test for a couple of different things at once. So
exactly,
if there is something suspicious going on with that lining, that it'll be discovered beforehand. So
definitely,
yeah. Do you see that with endometriosis, like a little bit higher correlation with the
I see. So I feel like I keep seeing more and more sort of what you alluded to, the chronic endometritis, which is distinct and different from endometriosis, which can get confusing because they sound super similar. But a chronic endometritis, as diagnosed by a biopsy of the lining of the uterus, is sort of like an underlying inflammation of the lining of the uterus that can impact implantation. And certainly there are a lot of things that predispose patients to that, but certainly I wouldn't say I see it more in endometriosis patients, because I feel like I see it across the board. But I would certainly be more suspect to make sure to check it in an endometriosis patient that doesn't have good control over their disease or has very severe or advanced endometriosis, for sure.
Definitely. That's it's one of our favorite things to treat in Chinese medicine, because it responds so well to natural treatments and that sort of thing. Different, obviously, like stage 1, 2, 3, 4, that can be really difficult. Sometimes we have to kind of blend the best of both worlds of that treatment. But we've had even young girls who were hospitalized because they had so much pain, and they did much better when we worked with them naturally. So so don't give up if you've got that going on. And it definitely it can affect fertility, but we have so many patients who have endometriosis with healthy pregnancies. So you guys do wonders for that too. And the ERA question, I was kind of like, weaving this in a little bit, but the next question was about the ERA test. Somebody mentioned that they did the ERA test, which, I mean, you can expound on that maybe for people that don't know or they're not familiar with that.
Yeah, sure. So and then I have the questions pulled up here too, so that's why I keep looking over there. So the ERA, or the endometrial receptivity assay, is a test that is usually indicated for folks that have recurrent implantation failure, because there is some thought that if you can identify the exact receptivity window of the endometrium in which it is receptive to the embryo, and perhaps if it shifted one way or another, it could possibly explain why implantation has failed. And the way that it is done is essentially you prepare exactly like you would for an embryo transfer, with all the medications and all the ultrasounds and time and all that kind of stuff. But instead of doing the embryo implantation or the embryo transfer, you instead take a biopsy of the lining of the uterus, and then it gets sent off to a company to do genomic analyses and to assess whether or not you have fallen in the appropriate window. I will say that and it is very physician dependent who uses this test. I trained with it, and I definitely especially offered it to patients that had, more than two, euploid embryo transfers that failed. But there actually has been recent data to suggest that it has not really improved live birth rate, at least in the fertility community. So I was never like a huge fan of it, also because there's cost involved, like everything, of course, and at least now, for something that has not really been shown to improve live birth rate, I will, of course, educate my patients about it and make sure that they understand the pros and cons, and then they can make their own choice if they think it's right for them. But I tend to be, especially with the recent data, a little bit more skeptical about it of recent, just because that new data suggests that it might not be helping as much as we originally thought. And to answer the question here, which is, you did the ERA and then you stopped vaginal progesterone and you started spotting, is that normal? Absolutely. Anytime you start, anytime you're on, estrogen, progesterone medication, and then you stop, you're going to have a reactionary sort of bleed from the uterus, and that's completely normal. And I would also expect you to get, full flow within a week or so after the ERA. So completely normal.
Good. And I know it's tempting because you want to know everything, like what's going on. Why am I not getting pregnant? Is this embryo transfer going to work? And I wish that there was something that could say 100% that it would implant, but it's not. Yeah. We're not there yet. Maybe we'll never be there, but it's like, but it's I guess helpful for a certain patient who really wants to kind of narrow down a window.
Absolutely. There's nothing that. It's our job as physicians to make sure that we educate our patients about all of their choices, and then they need to make an informed decision that's right for them. And and this is very much, I think we've said it before on this forum, this is very much an art. There's certainly science behind it, but very much nuanced. Some physicians do things one way and some do them another way, and that's good, because there are different kinds of patients who need different kinds of things. So it all works out in the end.
It's not one size fits all.
Definitely not.
And the next question is about weight gain with IVF. That's very common, I'd see.
It sure is. I'm sorry, Danielle. That might be my fault. But it's temporary, my friend. It's hormones and holding on a little extra water and all of that kind of stuff. Your sometimes appetite is affected a little, so you're eating things that you might not normally eat, but it is all temporary. And the ultimate goal of getting you pregnant. Certainly you're going to gain weight in pregnancy, and then that will be the ultimate goal, and then it'll just all magically come off at the end.
Maybe. Yes. Yeah. I mean, definitely when someone comes off of a cycle too, we are, we see that, it's like literally like everything starts to kind of get less puffy,
Yes.
All the water retention gets better. And
Yeah.
especially with, birth control and estrogen patches and all those things.
All the things to make you feel bloated, and like is that the one from Willy Wonka who turns into the blueberry? Veruca. I can't remember her name, but you know what I'm talking about, right?
Yeah, I can visualize that, yeah.
Anyway.
Yeah, definitely. It's frustrating though, I know, when you're going in between cycles and you can't exercise, and then,
Right.
you're told all these things. So I think that it's good to take a break sometimes too, if you've had several like IUI rounds or IVFs, that sort of thing. And hopefully that you don't have to go through a lot of those. But if that happens, to take a couple months just to kind of, regroup if you're not feeling mentally up for the challenge as well of getting right into the next cycle. So I think sometimes it can be like a little hamster wheel where you just keep getting on and getting
going. Yeah.
And it's tough. So that's another concern of a lot of people. So the next one is about high natural killer cells. So the person says high natural killer cells and need to do intralipids but have high cholesterol. Can it still be done?
It can. Even to my knowledge, intralipids have not been shown to negatively impact those folks who have high cholesterol. I would certainly, it's my view that if you do have significantly elevated cholesterol, that in fact can negatively impact the success of an IVF cycle in and of itself. So that should really be addressed prior to you going through, hopefully if you're getting your intralipids, you might be going for an embryo transfer, but getting that in check before doing your treatment and before doing your embryo transfer is really important, because that'll help you have a healthier pregnancy to begin with. Mm-hmm. And using things like more natural supplements, like omega-3, and staying away from red meat and egg yolks, and actually shrimp are pretty high in cholesterol, and full fat dairy, dietary adjustments can really make a big difference. I don't actually know the data on, can acupuncture help with cholesterol?
It's interesting. When I was researching this for a patient where they had a family history of cholesterol issues, we looked at theirs and it was definitely really elevated. I came across research that said stress can actually elevate your cholesterol.
Yes.
So that was compounding everything. So, and I definitely think that the more we address stress and cortisol balance, everything else kind of comes into play there and falls into place. So, that's one way it can help. And definitely we look at the omega-3s. We have herbs that are actually very good for that. And, in general, we take away the red meat because that to me has been the biggest difference with a lot of patients. Once they stop eating red meat, they can still eat, lean meats and things like that, but no more red meat. You really see the cholesterol go down quite a bit. So I think that can be helpful as well.
Absolutely.
And our next question is in Spanish, and I think it has to do with Mosaic Embryo.
Yeah, sounds like a 42-year-old, 4 embryos. I don't know what aptos is.
Oh yeah, I should.
But 1 mosaic embryo. Medium risk, like 40%, so a medium risk chance of mosaic. What are your opinions about that? So that's super tough, especially in women that are in their early 40s, going through cycles using their own eggs. Unfortunately, just the vast majority of embryos that women make at 42 and 43 and above are going to be abnormal in some respect. Mosaic embryos are, just for people who don't know, are embryos that have some cells that have a normal amount of DNA and some cells that have an abnormal amount of DNA. And there is some thought that that mosaic embryos can correct themselves as the embryo develops, but it's really not as much as known about it as we like. I can let you know that here at IVFMD we consider mosaic embryos abnormal, and therefore we don't transfer mosaic embryos back. There are clinics that will, in the country that will transfer mosaic embryos and or may even transfer abnormal embryos, and we can certainly direct you in that regard. But it's just very, unfortunately, super common in someone and women that are 40, in their early 40s, to have abnormal and mosaic embryos, because in all likelihood there's probably a stronger chance that embryo is abnormal. It just hasn't fully presented itself yet. So that's a tough spot to be in. I'm sorry to whoever submitted that. And yeah, I don't know. I'm not sure what Aptos is.
Mm-hmm. Yeah. If anybody else knows, chime in the chat. But definitely, and maybe there's like you said, you mentioned other clinics that might, because if that's the only one, was that the only embryo that was, it looks like, made it, or if that's their only embryo, is there like any recommendations that you would make as far as, you said you do have other clinics that might transfer those?
Yeah.
What would be the issue where it might result in miscarriage, or would it be more likely like a genetically, like, does the baby have a lot of genetic issues, or what would be the main concern with transfer?
Yeah, I'm trying to. Suitable. Aptos means suitable. Okay, so hold on.
Not suitable for embryo. Okay.
For embryos not Oh, okay. So not suitable. So probably abnormal, or maybe not suitable for biopsy. And then one embryo is mosaic. But I think that's what that means. Sorry, what was your question, Farrar?
Well, I mean, the biggest concern is miscarriage. Would that be it, or would it be a genetic abnormality with the baby?
Either or. That's actually both. Because whatever like this one has an extra third chromosome and a deletion on chromosome 1, and the cause of that, that could lead to either failure of implantation or miscarriage, or conceiving a child with a chromosome issue that could be compatible with life, but associated with significant abnormalities. And so that's the concern.
Okay. And we do have a question that popped up in the chat here. 36 years old, AMH 6.6, only 8 eggs retrieved. Doctor expected around 20 plus based on follicles. Any reason for less eggs retrieved?
So no, if you're 36 and have an AMH of 6.6, you are sort of falling potentially into that PCOS category, in my opinion, based on AMH alone.
That's what I was thinking, maybe.
Yeah, and so one of two things could have happened. Number one, you could have ovulated prematurely. Okay, some individuals ovulate prematurely, such that some of the eggs the follicles are released before the doctor has a chance to go and retrieve them. So that's one thing that could have happened. Number two, I don't know. Sometimes you can retrieve a bunch of eggs, but only a small portion of them will be mature. There can be a very high immaturity rate in patients with PCOS. And so that's definitely unexpected. And definitely something you should sit down and talk with your doctor about, but potentially premature ovulation, or significant immaturity in eggs could account for that. And I'm sorry that happened. I must be very, very frustrating.
Definitely. And it could be the protocol too, that they have to work, right? So it's called hard. It's a lot of trial and error sometimes.
Unfortunately, yeah, it's expensive trial and error.
Sure. And speaking of stimulation, I like how these questions are like flowing together.
I know.
It's like wonderful. That smoothly. And speaking of stimulation, there's a question that patient is or someone is asking, any tips for stimulation? I start Friday and I'm very nervous.
Oh, don't be nervous. It's okay. We're here to support you.
Yes.
Any tips? Let's see. Follow your instructions. Make sure you have enough medication. There's nothing worse than scrambling to get medication at the end. So make sure that you are prepared with having enough medication. Stay hydrated during your stimulation. Try to be as healthy as possible. That only will serve to help. Just stay positive. Make sure you're doing your acupuncture on a regular basis, and doing things that help you feel good and feel healthy, because you're gonna probably not feel 100%. Although some people don't even notice it at all, but there are some people that don't feel 100% for a little while. But just know you might gain a little weight, as we sort of talked about earlier. It's temporary, and it will pass. But just stay positive and make sure you follow your instructions, and make sure you ask questions. Don't be afraid to ask questions if you have a question. And I wish you the best of luck.
Yes, good luck.
Yeah,
baby does too. And and eat protein, right? Because I definitely think protein helps too.
Protein and hydration and electrolytes for sure.
Yeah, this is why I have I'm not stimulating, but I have a protein shake that I'm like. I'm on this like protein kick for dinner lately. So
okay.
Just want to have a shake for dinner, and I feel better.
Good for you. I had Greek food because that's what my husband wanted. So
I had that for lunch.
You win.
So I had that for lunch. It was delicious. But I was like, I had probably too much for lunch. I'm like, let's just have it. But I love those spinach pies. I forget the name of them.
Oh yeah, spinach.
I don't know how to pronounce them, but it was very good. Okay, so
we digress.
Yes. So and I can't intro into this as well, but there is a question about stress affecting chances of conception.
Yeah.
So what have you noticed with your patients about their stress levels and any correlation that you see there?
I mean, their stress is inextricably, I think that's a word. Inextricably linked to badness in everything. It can have a physical. Stress has physical manifestations that can have a negative impact, not just on fertility and trying to conceive, but really on everything. You think you might be having a headache for an unknown reason, but it's actually because of stress. These are physical manifestations of stress. And so stress management is really, really important during, when you're trying to conceive, when you're going through fertility treatments and whatnot. And, one thing that, because although I am a believer in acupuncture, sometimes I have patients that say, listen, I don't think it is, I've tried it, I don't think it works. And I say, but at the very least, it is you taking some time for yourself to relax, to de-stress, to turn off the world for a little bit, and that in and of itself is going to be beneficial for you. So yes, stress can affect your chance of conception, not contraception. Don't do that. Yeah, never mind. Of conception, and you should really take steps to try to manage your stress, however that fits for you, because it will definitely improve your chances for sure.
Yeah, and I can correlate it to if you've ever had a stressful situation and you didn't have your period, or it was late. Mm-hmm. That's like another way to kind of look at it and go, okay, well, I mean, I didn't ovulate where I was supposed to ovulate, so I was stressed about something. And then, it messes with the HPO axis, which is
absolutely
all of our these fertility drugs are based on. It's your pituitary, ovarian axis, and hypothalamus. So, I think how we explain it is basically your fight or flight is not meant to be a feed or breed response. It's meant to be to get you the heck out of any situation where you don't need to be. And your body will prioritize your survival organs over the ones that are not really necessary for survival, like our uterus.
Right.
So our blood flow can literally shut away from those things. And that's the body doing what it's supposed to do, is to keep us alive and, and so yeah, pupil dilation, our heart rate's accelerating. We have focus and that sort of thing, but we're not meant to be basically functioning in that particular state for too long. That's really
right.
an acute stage. It's supposed to be.
I almost fell over. Sorry.
So,
not me in particular.
No, not you. So, that would be an acute stress, like I'm falling, or I have somebody who's about to hit me on the palmetto. That's not good. But chronic is something that is worse for your body than acute stress. So acute stress is fine. It's just when we have something like chronic stress where we don't even realize we're stressed sometimes. I have patients that are like, oh, wow, I didn't even realize that I needed that, like they're just so used to it. And probably this pandemic didn't help with that either, and all kinds of other things compounding it. Your body needs to take time to be in parasympathetic mode, which is called rest and digest, or feed and breathe, and that's kind of where we should be for the most of our existence, and that's the place that we strive for. So it's said after 20 minutes or so of doing like a very deep yoga sequence or doing acupuncture, certain things, your body actually starts to go into that parasympathetic mode. So that's kind of why we say, oh, let's do 30-minute treatment. That's usually how long it is. Some people want longer, but we'll say 30 minutes to kind of help you get into that mode a little bit too. And we use fertility meditations, some essential oils. We have our massage therapist, sometimes they'll do a little massage session before that. So we do everything we can to help you get into that state before you get to your transfer, before you start stimulation and all of that. So your brain is going, okay, I'm good. I am totally fine with getting pregnant. And I can do this.
Let's do it. Yeah.
That's it. Yes. So we do have another thing that popped up here, a little question about PCOS. So it's a broad question about how to treat PCOS from Giova. Are there? And that's just where the question says is how to treat PCOS. But
so that's sort of a loaded question. There are different kinds of PCOS and a spectrum of disease when we're talking about PCOS. And so when we're talking about the goal in PCOS is, cycle regulation, if that is an issue for you. And a lot of ways that can be achieved is making sure that you are normal weight, that you have that your body is appropriately handling glucose, okay, that you're not pre-diabetic or diabetic, and then looking at things like your lipids, your cholesterol, and occasionally the use of specific kinds of, even if you're not diabetic, using a medication called metformin, which is a diabetes medication, can sometimes help in women that have PCOS. There are a lot of different ways to treat PCOS. But it has to be tailored to, there's no one size fits all. You need to have a full evaluation to understand what your version of PCOS looks like, so that each particular issue can be addressed specifically. So I definitely encourage you to, speak with someone who specializes in PCOS, someone like me, to really understand your variety of PCOS and how it can best be treated, because it's not a one size fits all sort of answer.
And this month's PCOS Awareness Month.
Sure is. Yeah.
Definitely. There is a PCOS panel. We always say, like, why don't we make sure people are aware of this, so that they know that they need to get a full workup done at least once a year. I think these are the new recommendations that came out a few years ago about PCOS. And maybe your primary doctor is not aware of these tests, or your gynecologist even, but they're looking at your thyroid and your cholesterol and your androgens and all those things that are important to keep an eye on. And as we get older with PCOS, it can have you can be more at risk for cardiovascular issues, things like that. So definitely it's important to address it even if you're not trying to get pregnant. And that's what I
Yes.
try to tell people. It's not just a fertility thing. It's
Definitely not. Has
systemic.
greater general health, implications that are arguably just as important.
Right. Yeah. And definitely with diabetes, right? We can
Mhm.
get a head start and work with that. And Marta is phenomenal
Mhm.
at working. We have patients that are insulin dependent diabetics and with PCOS and who are trying to get pregnant and who need to lose weight. So she's phenomenal at working with that and working with their doctors and trying to figure out the best options. So no matter where you are, it could be mild PCOS or it could be pretty severe, full blown. It's really good to have a team approach.
Always,
yeah.
always with a team approach. 100%. I couldn't agree more. Yeah.
And let's see, we have another weight gain question. I'm gaining weight from birth control. Does that mean I'll gain weight from the stems?
From the what?
Stimulation.
Oh, stimulation, from stimulation. No, and actually, well, it depends on what kind of birth control you're on. There's actually a pretty big misconception out there that that birth control pills are associated with weight gain, and they have done studies up and down, right and left, forwards and backwards, that actually show that generally it's not associated with weight gain. So a lot of times, women start using birth control in during a particular change or a time in their life when it becomes more important to be mindful of that, or like when they go to college or something like that. And often what we have found is that it's really other factors, not the birth control, that is associated with weight gain. There are certain birth controls that are associated with weight gain. In particular, the Depo-Provera shot has been shown to be associated with significant weight gain. But just because you have, taken the birth control pill and gained some weight does not necessarily mean that you will gain a significant amount of weight during stimulation. And just sort of as we alluded to before, even if you do gain some weight from stimulation, it's temporary. And it's certainly related to the fluid balance that you have and all of that kind of stuff. So it can definitely, it can come off, just as easily as it came on.
I heard there's a new plant-based birth control out, Nextstellis. I don't know if you've heard of
Ooh,
it.
no,
Yeah.
I'm not in the business of preventing pregnancy.
Right.
So,
Well, I just thought how interesting. Finally, after 50 years, there's a new type of estrogen apparently. So
okay.
I'm asking people if anybody has actually tried it.
Yeah, no, I haven't yet. I'd certainly be interested to learn more about it though.
Yeah, that was, I think last month it just came out there. So
oh, cool.
FDA approved. Yeah, that's interesting. Thank you. You're welcome. We love answering your questions, guys. And if you have any more questions, we still have a few more minutes, so don't be shy. Just type them in and we will get to them. Now's your chance.
Yeah.
And we do have a question about that was submitted earlier about fibroids interfering with conception.
Yeah, absolutely. So fibroids can definitely interfere with trying to conceive and getting pregnant. It's very dependent on where they are located within the uterus, how much of an effect they will have. And what do I mean by that? So some fibroids that are located inside of the uterine cavity itself can sometimes serve as a physical block for an embryo to be able to implant. And so it's really important that when you make sure that when you're having a fertility evaluation, that your uterine cavity is evaluated completely. Usually I prefer to evaluate the uterine cavity with something called a saline infusion sonogram, whereby we put some fluid inside the uterus and then use the vaginal ultrasound probe to identify if there's anything in there that shouldn't be there, like even like a polyp or a fibroid or scar tissue or something like that, that can really interfere from a physical standpoint. And so understanding and mapping where your fibroids are, having your doctor do that is really important in understanding if the fibroids are something that potentially need to come out, or if they are something that is, not contributing as much or at all to difficulties conceiving. So it really depends on the location and also the size of the fibroid.
Yeah, for sure.
Yeah.
And we've had patients get pregnant with fibroids, and then we could see like fibroid and then the baby. You know, it's like they're almost the same size sometimes.
Yeah, for sure, and it definitely can happen. It's just it can certainly also make it more tricky. So.
And okay, another question here: do you expect low quality eggs with a 31-year-old patient with Dor and Hashimoto's?
So it's certainly very unusual to be 31 and have diminished ovarian reserve, potentially related to some sort of autoimmune condition like Hashimoto's, and sometimes there's some thought that that translates over and crosses over into affecting egg quality. Usually what I see in women that are younger who have diminished ovarian reserve is that usually I get better quality than it's not going to be, your quality is going to be compromised because there's a quantity issue no matter what you do. But generally with younger women, they tend to have a better prognosis than older women, simply because the eggs have not been around for as long. And so yeah, I guess it's tough. I mean, I would encourage you to speak with your doctor about trying to investigate why they think you have significant DOR or diminished ovarian reserve at such a young age, and identifying, making sure that you're on a sort of a cocktail of supplements to help try to preserve what you have left, and getting into acupuncture to improve the blood flow and really try to, again, preserve what you have. So it's a little unexpected that, a 31-year-old would have very poor quality eggs, but in the setting of diminished ovarian reserve, I guess it's not entirely, it's surprising, but usually you're going to fare better. You have age on your side. You're going to fare better than if you were 41.
Very good. Yes.
Yeah.
There's definitely a lot of hope there.
Yeah.
And
for sure.
Sorry, I have a tickle in my throat just now. Okay. We have another question that popped up about another AMH 6.7.
Okay.
33 years old, ovulates regularly based off levels of progesterone blood work. Is it possible to still have PCOS?
Yeah, absolutely. There are other elements of PCOS. There are cycle regularity and ovulation are only one piece of it. You need to have an evaluation. You need to see what your ovaries look like on ultrasound, have your androgen levels checked to really truly understand if this is a PCOS scenario, or are you just someone with very high reserve without any sort of consequence. And so, yeah, I guess the short answer is, yeah, I do think it still could be, but you need, it's tough to answer these questions without being able to take a full history and ask all the questions that I want to. But, I think it's certainly possible.
All right. You can still ovulate and have PCOS.
Absolutely. Absolutely. Yeah. You might not be ovulating as well as you would ovulate if you didn't have PCOS, or as robustly or enough, although it sounds like this patient has good progesterone levels, documented after ovulation, but certainly you can still ovulate with PCOS.
Yeah, for sure.
Yeah.
Even if you ovulate like on day 30, 40, 50, you can still have a healthy pregnancy. It doesn't have to be day 14, for sure. And there is a question about, let's see. Oh, we did that. 7.2. Is 7.2 a high AMH consistent with PC? So I guess if you could give it the range of what you're looking at.
Yeah, so it depends on what lab you have your AMH drawn. I almost exclusively use one lab because it helps me be consistent so that I know exactly what that number means. And in general, a normal AMH level is anywhere between 2 and 5. Okay. And and then I have in my head, based on this particular lab that I use, it's called Unilab, what are the averages for specific age ranges? And so for me, and how old was the person? I missed that.
33.
33 with an
AMH of 6.7. The 7.2, we're not sure.
Oh, okay. Yeah. So again, that has to be taken in context. If you're 22, an AMH of 7.2 could be completely normal. Because that's sort of like you're the peak of your reproductive years technically, and so it really depends on your age, and it depends on a lot of other things. For me, I would certainly, if I was just given an AMH of 7.2, I would certainly investigate for other factors that could maybe signal me to thinking that PCOS was at play.
Yeah, more information we want to
Yes.
see. And ultrasound too, right? So
Yeah, absolutely.
it's not always diagnostic, but you can see, oh, there's a ton of follicles here, or that sort of thing. And then there's 3 characteristics to PCOS, right? Like,
Exactly.
So irregular
cycle regularity,
high
androgens, and how the ovaries appear on ultrasound. And you need 2 out of the 3 in order to be diagnosed.
Yeah, and I don't think AMH is mentioned as a diagnostic for PCOS.
It's not at all.
Yeah.
It's not at all. Actual, interestingly, the only thing that AMH, from an evidence-based medicine standpoint, does well is predicts how well you will respond to stimulation with IVF medications. That's the only thing that it reliably does, but we use it for a lot more, based on our experience and based on how often we use it and how often we see it. But it's not, you're right, it's not included in PCOS diagnostic criteria at all.
Yeah, and definitely it's, if we talked about this before, if you've had it at another lab and then you go to another lab, it can be look so different, depending on
exactly. Yeah. And that's the tough part about it, and that's generally why, like, I ask my patients to do it at one specific lab, because I have a better idea as to what that number really means.
Yes.
Yeah.
And we have actually, let's answer our last pre-submitted question, and then we'll get to a few of the questions that have popped up in the chat in our last few minutes. So the question was, should you have sex every day in fertile window if possible?
You can, if that's what strikes your fancy. It's assuming you have normal semen parameters. It's not necessary. You can very easily do every other day, because in general, sperm sticks around for anywhere from 24 to 48 hours and can be viable in that time frame. And so you're covered from if you're having sex every other day. It's perfectly reasonable, but if having sex every day works for you, then I don't think it will cause detriment.
Yeah, as long as the sperm count's good and healthy and that sort of thing, right?
Yeah, absolutely. Yeah, go for it.
So, and that's a question that comes up a lot too, about if people are people aren't traveling as much lately, I guess, but it used to be that our patients would be in one end of the country and another during ovulation, and what to do during that time. So we did have a patient whose partner traveled 5 days before she ovulated. She thought, there's no way I could not be pregnant. I mean, we totally missed it this month. Well, she had a little girl, beautiful girl, and you never know. So
no, you never know. You never know. Sperm can stick around for quite a while, so that's a good thing.
And so we have another question. Have had recurrent implantation failure with 3 PGT embryos. All tests and imaging are normal. What would you investigate?
That's a tough one. I guess that would be a scenario where having a conversation about an ERA, an endometrial receptivity assay, would be appropriate after 3 implantation failures. I would check natural killer cells. I would check for antiphospholipid antibodies. I'd consider potentially using a blood thinner like Lovenox. I might, sometimes there's a role for endometrial activation, which is actually doing a scratch of the lining of the uterus a couple weeks before you're before your implantation to really activate the cells there and whatnot. You also need to take a look at what the thickness and the architecture of your lining was, if that was at play, doing things to help thicken the lining, including, acupuncture and Chinese medicine and whatnot, to help improve it. There's a lot of things that need to be investigated as to why that could be happening. And then, of course, when all else fails, if every stone has been unturned and you've done everything, the, one thing to consider is potentially using a gestational carrier if every stone has been unturned and you can't find something wrong.
Definitely, and I wonder if there have been any autoimmune tests done, because a lot of places don't do the testing that you guys do as well.
Yeah, for sure. Yeah, it plays a role. It definitely plays a role for sure. So, get yourself to IVFMD. We'll figure it out.
We're sorry that's happened too. This is one of those tragic things. So I hope that you find answers wherever you are, and definitely, we're here to help too.
Absolutely. It's a very, very frustrating and trying thing to get so far as to have a beautiful embryo and then just can't get it to stick is endlessly frustrating for just as much for patients and for us too, because all we want is to help our patients. So sometimes getting a fresh opinion, a fresh set of eyes on your case can help, and so that's why we do free second opinions if you give us records, and just to get some ideas out there. It's not about getting your business or whatever. It's about making sure that you can achieve your family goals. That's what we're about. So I think I hope you can find an answer, and if I can play any part in it, I'd be happy to.
Definitely, yes. And we have, I skipped over one question about can blocked fallopian tubes be congenital?
Congenital? No. Short answer.
Okay.
No. Not that I know of.
I mean, maybe malformation of the uterus, right? But
absolutely, malformation of the uterus can be, but having blocked tubes, not to my knowledge, but almost always there is some, whether I guess in a way, if you consider that and how endometriosis plays a role, sometimes patients with endometriosis can, which has been shown to have some genetic component to it. So because endometriosis can, if the implants are on the fallopian tubes, it can scar and damage the tubes. So potentially, if endometriosis runs in your family, then you may have an increased risk for having blocked tubes. But far and away, a more common scenario is a history of any sort of pelvic infection or surgery or something like that has affected the tubes. But no, there is no congenital blockage of tubes that I've ever read about per se.
And the last question we have is anxiety from the birth control a normal side effect?
I have definitely had patients say that they don't feel themselves on the hormones and whatnot, and that's sometimes exacerbation of anxiety or depression or whatnot, and it's very patient specific. The only thing I can say is as long as of course you're safe and you're not putting yourself or others in danger, that to try to give it some time, because usually it makes sense that your body would have a reaction to to hormone, giving yourself, any form of hormones, and, giving it some time to even out and let your body get used to it may be beneficial. If you can stick it out. It's not like in the textbook that birth control pills absolutely cause anxiety for sure, but I have definitely seen it, and I'm, you need to also consider that anxiety is super multifactorial. It has, your home life, your work life, your everything, contributes to it. And so potentially focusing on how to better manage those aspects can be beneficial. And to that effect, birth control is not right for everyone, and maybe changing the method or the mode that it's delivered or the brand or something like that might also help you as well.
Maybe it's just short term because you're about to do an IVF cycle and you're ready to get off that birth control.
100%.
That could be it. Well, I really want to thank everybody for your questions.
Yeah.
And also, if you could, they could find you at Jessica Bauer Fertility Doc, right? So
Jessica Bauer _fertility doc.
Yes. So follow Dr. Bauer on Instagram. I'm at FL Complete Wellness. You can follow us too. That'd be great. And we also have a YouTube channel where we're putting all of these awesome Q&As. So, and it's under Farrar Duro Fertility Specialist under that YouTube name. So if